So Dr. Scott Genshaft will be our first presenter. He is the Associate Clinical Professor of Radiology at UCLA. He completed medical school at Case Western, which is where I currently attend, and completed residency in radiology, as well as fellowships in IR and thoracic radiology at UCLA. His clinical focus is lung ablation as well as genicular artery embolization.
I'm very excited to talk about this topic of genicular artery embolization as I get this loaded up, because we've been doing this quite a bit for the last several years, and it's fantastic. It's provided kind of an interesting novel therapy that interventional radiologists can perform. So this is just a brief overview. I want to minimize this because I can't see stuff. Give me a second. I'm not good at oh, whatever, I'll deal with it. Okay. Sorry about that, guys. So I just can't see half my screen, so bear with me. So this is a typical case that comes in. Older guy, previously active, lifestyle's been limited because of his arthritis. He has a lot of pain and whatnot, and has had failed conservative management, which usually involves a number of different medications, but possibly opiates, physical therapy, injections. And so they're looking for something else, but kind of like not necessarily interested in a total knee arthroplasty. And so when these patients come into our clinic, we do a full clinical examination. We see them, we look at their knee, we make sure it's not unstable, which would definitely require having a surgical correction. Usually it's just pain. And so we evaluate them with this WOMAC score to kind of evaluate kind of the severity of their knee osteoarthritis and how it's affecting their life. And you can see this patient had a pretty high score of 56. So, knee osteoarthritis, traditionally, I think of the way it's often taught in medical school, at least how I kind of remember it being taught at Case when I was there so many decades ago, is kind of a disease of wear and tear of the joint. But as a result of that, in the cartilage loss, there's a lot of inflammation that occurs, and that sets up a series of cascades of interleukins and whatnot, things that I have no idea about, but really precipitates the pain. And so synovitis is a huge part of the pain that is associated with osteoarthritis. And here's just some examples of the partially visible screen for me of how the knee kind of breaks down and kind of this exposure of the bone beneath the cartilage and how that kind of precipitates this cascade of inflammation. And it's kind of a vicious cycle, right? So bone wears down, you get inflammation, bone wears down more, you get less active, you get more pain because you're less active, and it's a real problem for patients. And so that's why this kind of came into play. So actually, people have been performing genicular artery embolization for many decades for hemarthrosis, so patients that have, difficulties, blood clotting or trauma or this and that. People have performed this before specifically to stop the bleeding inside the joint. But it wasn't until Acuna kind of approached this in a more novel fashion about a decade ago that people started to perform genicular artery embolization for the purposes of treating pain due to knee osteoarthritis. And this is just the anatomy of the knee joint. Now, I can tell you, vascular anatomy is generally not predictable. So these are the vessels that you will see, but it's variable if you'll see them in every case that you perform. And so as a result of that, there's a whole number of diagnostic methods we employ in order to kind of work up which vessels we're going to treat. This is the setup for a genicular artery embolization. Usually takes somewhere between 60 minutes to 2 hours. We do it with moderate sedation. It's an outpatient procedure. We do it actually a lot in our outpatient centers where we have excellent equipment here at UCLA. Basically, we get to access into the common femoral artery, ideally in an antegrade fashion. It makes the procedure a lot easier. We typically use a micropuncture sheath alone to get access, or a 4 French glide slender sheath to keep it really small. You do manual compression at the end of the cases, and then we perform an angiogram once we get access. We're looking, to make sure we don't have to send the patient to Dr. Vatican Sherry to work on their PAD, and if they don't have any severe occlusions, which we've hopefully caught ahead of time in our clinical evaluation of the patients. we go ahead and do an evaluation of the genicular arteries. So you can see a number of the normal genicular arteries that are pacifying on this catheter angiogram. In our practice, we also perform a cone beam CT. And this is really useful. This is not the set of images we typically use. We actually use these three-dimensional images to kind of select the orientation that the vessels are arising from to facilitate catheter selection. But what we specifically use them for is to identify the vessels that are going to the areas of pain in the patient's knee. So interestingly enough, when you start seeing these patients, a lot of them can really localize where they're feeling pain, and it's often medial. And so we kind of look for all the vessels that are going to that area. So we don't necessarily treat every single genicular artery in every patient. But if it looks like it might be going to that area, we treat it. And then we take a microcatheter, usually an echelon, go down, select the genicular artery, perform an angiogram, inject a little nitroglycerin so that we can make sure there's no vasospasm. These vessels can vasospasm. And then we inject very small particles. We typically use 100 micron embozine in this context, a little bigger when we're treating patients with hemarthrosis, but 100 micron embozine. And we're aiming to just prune the vascular tree. So we're not aiming to cut it off at the trunk. We just kind of want a little pruning of the hedges, and that's our goal. Now, why is that our goal? Yeah, that's what we think is the best idea. We don't really know, but that's generally how we approach these hyperemic kind of areas in the body, like fibroids and whatnot. And then, this is our results. So this patient went from we saw this patient 2 weeks follow-up, but we actually typically don't see these patients until 3 months follow-up. And the patient's WOMAC score baseline was 56 and went down to 26. So that's a significant improvement in the patient's pain. This is an evolving field. Okay, a lot of single-arm trials were initially published in a couple of randomized controlled trials. We have one in process, which we'll talk about in a bit briefly. But the results are very similar. We're showing a high level of efficacy, greater than 60% up to 80, 90% across most of these trials, which is pretty darn interesting, because in the field of pain, and Sean will talk about it in a little bit, you don't always achieve supreme efficacy. Pain's a very complex process. People have different reasons for pain. So if you can make any impact and potentially get these patients off their narcotics, that's super important. Oops, sorry. So I think we can move past this. I'm jumping around a little bit. We did a trial. Our first trial was this single arm trial, kind of included patients with visual analog scale greater than 4. We included people with arthritis ranging from 2 to 4 on the Kellgren-Lawrence scale, 40 to 80 years old. Interestingly, most of our patients were of higher severity osteoarthritis of their knee. And what we saw is we had very few complications, okay? Often these patients will get a little bit of discoloration of the skin overlying the area we've treated due to a little non-target embolization. We put a bag of a cool pack on the skin in the area we're treating before we actually treat, so that we vasoconstrict those blood vessels so that they don't actually see these particles. That's been very helpful. We don't get any ulcers anymore. At least it's been a very long time. When we did get ulcers, they resolved in a couple of weeks, very small. And this was our efficacy. So we defined efficacy as a 50% reduction in their pain score. In our practice, we don't believe that 20% really is meaningful. We want a significant decrease in the patient's quality of life score, the WOMAC score, to call it a successful procedure. Otherwise, it's kind of very prone to the placebo effect. And interestingly enough, so we saw that in 68% of patients. Interestingly enough, when we looked at our 1-year analysis, almost all of those patients for whom this was successful still maintained efficacy. So that's at a year. That does not happen in joint injections. Maybe you'll get 3 months out of them in the best case scenario. Also, interestingly enough, I can tell you off the record that at 2 years, there's only a little bit of attrition in the efficacy. Now, at 3 years, there probably is more attrition, but to provide that durable relief of up to 2 years, pretty significant. We've refined the technique over time, all these things we've mentioned. We still are looking at, there's a lot of challenges in this space. In order to be widely accepted, we're going to definitely need randomized controlled trials. We're in the process of our own randomized controlled trial. But the reason for pursuing this space is that GAE, if you're looking at like the impact we can have on people, it is a great area to be in because it's a ubiquitous process. And yes, there are other therapies that are fantastic. Total knee arthroplasty is fantastic, but it is a surgery. And it's not the first surgery that's the problem, it's the second surgery. So these joints only last 10 to 15 years. If you're getting a knee replacement at the age of 55, you can get one more, two more in your life, and that's a real disaster. So the FDA is unlikely to fully approve this with just these single arm trials. We've seen that repetitively in IR. So we're going to need randomized controlled trials in order to prove to our, orthopedic surgeon and rheumatology colleagues that this is a really, really good idea for a large number of patients. And that's why at UCLA, we've embarked and started to enroll in our Gravity trial, which is basically a randomized trial comparing patients who are getting genicular artery embolization to conservative management. There's a crossover at 6 months. We're about 10 patients in at this point. So the results, we'll be looking at, baseline 6-month and 2-year analysis. So we're still probably about 3 years away before publishing this for you all. But it's very exciting. And I can tell you, I think it will be positive, hopefully. And that this can really establish IR in another area of therapy that could be super impactful. So in conclusion, I don't want to waste time. I see there's like a lot of probably questions. This is a potential breakthrough area for IRs to treat a ubiquitous problem of pain due to knee osteoarthritis. In my personal opinion, where I think that will have the most impact is patients on the extreme range of ages. So young people for whom we want to delay a total knee arthroplasty, or older people who we want to get to the finish line of life without having to have another surgery. I think that that's a huge number of patients, so we can make a major impact in their lives. But we need more data. Okay, what we have right now is insufficient, even though there's a lot of great anecdotal evidence. And unfortunately, this has become a widely practiced area. Vascular surgeons are getting into it. We know their microcatheter skills are terrible. Apologies to anybody that's going into vascular surgery, but it just happens to be true. And so it's possible that this might just get ahead of us because it's just more widely applied than the science. That's it. That's all I got for you today. So I'm happy to field any questions that you might have.
Thank you, Dr. Genshaft. I believe Dr. V posed a question. How do you exclude alternative causes of knee pain? So palatofemoral syndrome or Baker's cyst, et cetera.
So we don't, so patellofemoral pain, we actually treat patients that have patellofemoral osteoarthritis, and have not noticed less success. Okay. As far as Baker's cyst, yeah, I think that if a patient's really complaining of pain in the back of their knee, that's very important. And actually, we take note of that. So when patients have pain in the back of their knee, these are not good candidates. There's no blood vessels that go and supply that area as far as the knee joint. And so it's unlikely that our treatment's going to be successful. Now, we don't necessarily work up a Baker's cyst or other pathology, but those patients we generally would exclude. So it's a great question.
Awesome, thank you. And another question, what are your thoughts on treating high KL scores?
Super in favor. So we thought that those patients, just because it's more end-stage osteoarthritic process, would not have favorable outcomes. That is not what we found so far. Okay, we're not finding any significant difference in their outcomes versus patients with lower KL score. So they're not excluded. Now, the thing I think that you have to is very important. When they come to clinic, you have to do a physical exam. Occasionally, what's the number? I don't know, maybe 1 in 20 comes in. They're very unstable. That is associated with a higher KL score. And if their knee is unstable, they need to go to a surgeon. It's like you're not doing that patient any benefit in not addressing something that's going to cause them to fall and have a hip fracture or some other major trauma.
Awesome, thank you. One question, what medical management should patients have failed before considering GAE versus nerve block? Should they just have failed CSI? What about other IA, gabapentin? I know there are mixed guidelines. What are your thoughts on that, Dr. Genshaft?
My thoughts are that we should be really open-minded. Okay, I think that what you definitely want to avoid is somebody that's only had pain for 2 or 3 months. in those patients that have come into my practice, sometimes they've actually had a fracture that we've identified that's been undiagnosed. We always get a pre-op MRI, so sometimes it's been kind of a fracture only seen on MRI of the cartilage. So I think you want to exclude an acute pathology. Now, if a patient's on NSAIDs and even Tylenol consistently for a matter of months and doesn't want to take them, I will consider therapy. Certainly, I want to consider therapy before any narcotics. They do not have to fail an injection in my practice, because these injections, the data on them is also not robust. It's just been it's been practiced for a long time. So that's the issue with so much we do in IR, right? I hate to draw into what you highlighted, the other part of my practice, which is most of it, which is lung ablation. But the only problem we have in lung ablation is we came second. Can you imagine like what people would have to prove in order to take somebody who could do an ablation in 30 minutes under moderate sedation, and then send them home and then say, we're going to bring them in, chop open their chest, take out part of their lung. And we think that's a better idea than that. So I think we should be open-minded, but also be, very critical of how we practice. Those are my general thoughts. I take each patient as an individual. I would say in my practice, I only bring about 50% of them for therapy.